Assalamu alaikum. This is part one of the presentation on dry mouth, xerostomia, salivary hypofunction, the causes, the diagnosis, and the assessment. Hyposalivation and xerostomia are not the same. Hyposalivation is the objective reduction of salivary flow. Xerostomia is the subjective feeling or sensation by a patient of a mouth dryness. They are not the same. For hyposalivation to be diagnosed, certain measurements has to be done. And although there are wide variations in the amount of saliva produced by a normal person, the unstimulated whole saliva flow rate of less than 0.1 milliliter in a minute collected over a period between 5 and 15 minutes could establish a diagnosis of hyposalivation. In addition, the stimulated saliva production by chewing, for example, the flow rate should be less than 0.7 milliliter in a minute, collected over a period of 5 minutes. So that's an objective diagnosis for hyposalivation. Xerostomia is a subjective. It's when a patient feels his mouth is dry. The salivary secretions has to decrease to almost half of its normal value before an individual will begin to experience xerostomia. Even then, some patients with hyposalivations are not xerostomic, and conversely, some patients who have xerostomia may have normal salivary flow rate. This is because dryness of the mouth or xerostomia is not only related to the amount of salivary flow, it's also related to other factors. Changes in the saliva consistency and composition, factors like mucin. If mucin is increased in the saliva, give it a thicker consistency, then patients may describe xerostomia. Changes in salivary calcium as well. If the higher concentration of calcium in postmenopausal females would also give rise to a sensation of xerostomia despite the patients having a normal flow rate of saliva. Abnormal low salivary film thickness or oral mucosal disease could also lead the patient to feel dryness, or changes in the patient's perception mechanisms. All these factors could lead to xerostomia without necessarily having a reduced salivary flow rate. How common is xerostomia? Somewhere between 10 and 50% of the general population. That's huge. A conservative estimate of about 20% of the general population is referred to in several texts. It's commonly found more in females and more in older adults, where the prevalence could be up to 30%. Certain medications, certain diseases and disorders, age are all important factors as well, particularly Sjögren syndrome and head and neck radiation, where the prevalence of xerostomia would be almost 100%. Hyposalivation can be very disturbing. It gives generalized oral discomfort. It makes wearing dentures intolerable. It causes dysphonia, dysphagia, and difficulty in chewing food, sleep disturbances, halitosis. Plus, it may induce oral mucosal disease, inflammation of the salivary glands, dental caries, impaired nutritional status because swallowing and chewing is difficult, and risk of depression and social isolation. There may be several mechanisms for hyposalivation, including salivary gland parenchyma disorder or destruction of the parenchyma itself, or a problem in the neurotransmitter receptor dysfunction, whether this is acetylcholine receptors or alpha or beta adrenergic receptors of the autonomic nervous system. It may be an immune dysregulation that may interfere with the secretory process and prevents the release of zymogen granules, for example, or the transportation of fluids across the acinar cells. It may be radiation-induced cellular DNA changes or alteration of the fluid and electrolytes balance in the serum itself. More generally, it can be a combination of all the above or some of them. The common cause of xerostomia is drug-induced. This can be associated with more than 400 different medications, including classes like antidepressants, antipsychotics, antihistamines, and antihypertensives. We'll go through the whole list shortly. The main other causes of the xerostomia are aging, radiation to the head and neck region, and Sjögren syndrome. Of the majority of the more than 500,000 patients who have radiation treatment for their head and neck cancer annually would suffer from xerostomia. There are more than 4 million patients with the chronic condition of Sjögren syndrome worldwide. Also with age, particularly with the polypharmacy that increases among the elderly, xerostomia is much more common. But the whole list of the etiology is much longer. It includes things like developmental disorders with salivary gland aplasia or agenesis, autoimmune disorders and chronic inflammatory disorders. Sjögren syndrome is only just one of them. Rheumatoid arthritis, juvenile idiopathic arthritis, systemic lupus erythematosus, and primary biliary cirrhosis, sarcoidosis, and endocrine problems including diabetes insipidus and diabetes mellitus and hypothyroidism, neurological problems and psychiatric problems including anxiety, depression, and Parkinson's disease. There are also several metabolic causes for xerostomia, including dehydration, chronic renal failure, bulimia, anemia, and alcohol abuse. Infectious diseases could cause xerostomia, including HIV and hepatitis C, and several other factors, including graft versus host disease, radiation therapy, and of course medications with anticholinergic or sympathomimetic drugs, antihypertensive, cytotoxic, anti-HIV, opioids, and anti-migraine medications. The medications that can induce xerostomia as their side effects generally falls into these two categories: medications with anticholinergic activities like atropine, for example, including hyoscine and ipratropium, tricyclic antidepressants, monoamine oxidase inhibitors, phenothiazines, and other medications including antihistamines, ganglion blockers, clonidine, and antiemetics. The other group are medications with sympathomimetic activities like cold medications, decongestants containing epinephrine or phenylpropylamine, and medications used in asthma like bronchodilators, isoprenaline, or appetite suppressants, particularly amphetamine and diethylpropine. Sjögren syndrome is one of the major causes of xerostomia. This is a chronic autoimmune inflammatory disorder characterized by lymphocytic infiltration of the exocrine glands in multiple sites, primarily the lacrimal and the salivary glands. It can occur alone and then termed primary Sjögren syndrome, or in conjunction with another autoimmune rheumatic disorder when it is a secondary Sjögren syndrome. The prevalence is somewhere around 0.6% of the general population. Highest prevalence in the 4th and the 5th decade of life. It's 90% of the patients are females. The focal lymphocytic infiltration of the exocrine glands may lead to germinal center formation, consisting of around 80% T cells and 20% beta cells. This will produce antibodies and cause focal sialidinitis or inflammation of the lacrimal gland. Cytokines may also play an important role in the pathology. The clinical picture would be that of a dry eye, the keratoconjunctivitis sicca, and a dry mouth. There will be extraglandular manifestation as well, including transient or chronic bilateral enlargement of the parotid or the submandibular glands, seen in between 20 and 30% of the patients. There may be some oral complications, including dental caries, candida infection, difficulties with eating, swallowing, and speaking, and a general sense of fatigue and arthralgia. In the primary Sjögren syndrome particularly, there is a high risk of developing a non-Hodgkin's lymphoma. The risk is more than 18 times that of the general population. There is also a high risk of developing autoimmune thyroiditis. 1 in 8 patients will develop autoimmune thyroiditis, or autoimmune hepatitis, interstitial lung disease, and interstitial nephritis. Interestingly, the minor salivary glands of the palate may not show the full manifestations of Sjögren's disease, the lymphocytic infiltration of the salivary glands. The diagnosis of Sjögren's disease could be established by objective measurements of saliva outflow and objective measurements of tear secretions. Salivary gland biopsy, usually taken from the lower lips, minor salivary gland biopsies, would also confirm the diagnosis and help in the scoring of the chronic inflammatory process. Estimation of the autoantibodies in the serum, serum autoimmune antibodies in patients who have Sjögren's syndrome could have the antigen, the SS-associated antigen A or B, and recently the ultrasound, high frequency intraoral imaging is used in the grading and confirmation of the diagnosis of Sjögren's syndrome. And in addition to the effect of medications and some specific diseases on the salivary glands function, age can also induce some changes in the salivary glands histology. The secretory acinar cells may be replaced by fibrous or adipose tissue, and the acinar cells could lose up to 40% of its volume. This does not happen uniformly in affecting all the salivary tissue. It affects the submandibular glands much more than the parotid glands, for example. So it's mostly affecting the submandibular and the sublingual glands, to a lesser extent the parotid and the minor salivary glands. It does not only affect the volume of the saliva secreted, but also its composition, with a decreased sodium and increased potassium concentration of the saliva. And also with age you would have increased levels of IgA and proline-rich proteins and antimicrobial proteins such as lactoferrin and lysozymes. The effect of age on the salivary gland functions affect both the stimulated and the unstimulated salivation. Both decrease with age, but it is the stimulatory part which is affected much more than the unstimulated part. The stimulated part of salivation induced by periodontal receptors is diminished, along with the lower chewing forces and the fewer natural teeth remaining. The resting saliva is reduced even in healthy individuals, but it remains adequate enough to maintain oral mucosal moisture. In general, the number of chronic diseases and medications increase several folds with age. Many of these medications, more than 500 different drugs, could have the undesired side effect of hyposalivation and xerostomia. But in the absence of a major medical problem or in the absence of frequent medication, the saliva composition in the elderly remains reasonably adequate, with diminished but still adequate reserve to maintain oral mucosal moisture. If this is lost, then there is either another condition, another chronic disease, or the medications, or a specific problem in the salivary glands. Another important cause for xerostomia is radiotherapy for the head and neck cancers. This is the commonest complaint of head and neck cancer survivors. Those who are actively taking the radiotherapy, about 93% would describe xerostomia, and following the radiotherapy course, between 74 and 85% would still feel the xerostomia. The radiotherapy-induced xerostomia would vary, the degree of the xerostomia would vary with the radiotherapy field and the dosage and the technique. The intensity modulated radiation therapy, IMRT, has a significant value in reducing the prevalence of xerostomia after radiotherapy. The IMRT decreases the radiation dosage to the tissues adjacent to the primary focus of the radiotherapy. Still, there is no reduction in the local control or survival rates, but the tissues around the primary focus of the radiotherapy would be spared the irradiation. Radiotherapy has a significant effect on salivary glands functions. During the first week of exposure to radiotherapy, a decrease between 30% or 50% of the salivary flow rate could be noted. after 7 weeks of conventional radiotherapy, the salivary flow rate would be reduced to just about 20% of the baseline flow rate. The radiation-induced salivary gland dysfunction is unfortunately irreversible. Slight recovery of salivary functions a year or a year and a half after the treatment dose has been reported, but the general consensus is that most of the effect of radiotherapy on the salivary gland function is irreversible. Because the effect of radiotherapy on salivary gland functions is irreversible, and we still don't have any effective mean of reversing or reducing these effects after it has been established, prevention is of prime importance. Oral pilocarpine, or perhaps high doses of topical pilocarpine, may reduce the frequency and severity of radiotherapy-induced xerostomia if taken before or during the radiotherapy treatment. Also, intensity modulation radiotherapy would reduce the frequency and the severity and long-term effects of salivary gland dysfunction. Some radioprotectants, such as amifostine, may be of some advantage in preventing the radiotherapy-induced xerostomia. Xerostomia patients would describe several symptoms. Only 4 of them would correlate positively and significantly with the objective measures of salivary flow rate. These 4 symptoms are oral dryness when eating, the need to sip liquids to swallow dry food, difficulty in swallowing, and the perception of too little saliva. These are the most important 4 symptoms. Other common symptoms include feelings of dryness upon waking up at night and keeping a glass of water at the bedside, the use of candies or chewing gums or mints to stimulate salivary flow, speech difficulties or eating disorders, which may lead to a compromise in the nutritional status of the patient or causing problems with his social life, taste disturbance, because saliva is important in dissolving the food chemicals that would excite the taste buds. Also things like halitosis or burning sensation in the mouth or the tongue, and intolerance to acidic or spicy food. And patients who wear dentures would find it difficult to have their dentures, with having more sore spots and difficulty in retention of the prosthesis. We move now to quantifying the patient's symptoms, the xerostomia or the dryness, and its impact on his quality of life. This is particularly important to assess the patient's response to management and also to see if the condition is deteriorating with time or with further management plans, including extra radiotherapy management. There are several of these. Some of them were developed for xerostomia patients in general, and some for xerostomia patients following radiotherapy treatment. One of the simplest questionnaires was the Xerostomia Inventory, which would quantify the patients of xerostomia in general by asking them some very straightforward questions, and they would have to grade it between never and very often. Basically, these are the sense of dryness in the mouth and how they attempt to alleviate it by sipping liquids, for example, or sitting up at night to drink, or having to suck sweets or candies, or if they have difficulty with eating dry food or certain types of food, or if they feel their skin of the face or their eyes or their lips or their noses are dry. The Groningen Radiotherapy-induced xerostomia questionnaire is quite similar. In addition to questions about the xerostomia, it also includes questions about the quality of life of patients receiving radiotherapy for head and neck cancers. Things like whether the patient have difficulties with eating due to the sticky saliva, or difficulties with talking, or difficulty with sleep, all are important aspects of impacting his quality of life. The most recent and perhaps the most comprehensive of these scoring systems is the system suggested by the Multidisciplinary Salivary Gland Society questionnaire in 2021, which includes 20 different questions. The first 13 questions are very similar to the last two scoring systems, but it have another section related to problems of the salivary glands itself, like if the patients feel any sense of tightness or itching in the salivary glands, or experience swelling in between meals or during the meals, or have any persistent swelling, or if they have to take antibiotics for salivary glands swelling, and if the pain is caused by this swelling need to be evaluated, or if they have any discomfort by the salivary gland swellings. So it has a separate section for salivary gland problems, in addition to the usual questions of the impact of xerostomia on the patient's quality of life, and describing his dryness, the intensity of the dryness, or the frequency, the quality of the saliva and the taste, and the impact of this on talking or chewing, or sense of dryness in the lips or the nose or the eyes. There are two ways of scoring the Multidisciplinary Salivary Gland Society questionnaire. One of them, the Q3, is by answering the questions by choosing one of 5 different answers. The other way of scoring, the Q10, is by a visual analog scale along a line of 10 centimeters, choosing a point along that line. Both ways, the Q3 and the Q10, are very reliable, more than 90% reliability for both both scoring systems. A healthy volunteer would score about 19 for the Q10, whereas patients who have xerostomia would score, the mean of the patients with xerostomia would score around 50. The developers of the MGSG recommends using the second way of scoring, the Q10, with the visual analog scale, rather than the Q3 with the question answering. Moving to examination, the oral examination of patients with xerostomia would show problem with the teeth itself. It may be dried up, or it can have caries or gingivitis. The tongue may be dry and fissured. There may be evidence of candidal infection. There will be absence of any signs of salivary pooling in the floor of the mouth, and there may be some purulent discharge in the salivary gland ducts. Dental caries are usually much more prevalent in patients with dry mouths, particularly the older patients and patients who have dental restoration works, and those with gingival problems or gingival recession. And the extraoral examination would include examination of the major salivary glands, whether they are enlarged unilaterally or bilaterally, and whether there is any abnormalities in the saliva, on pressing on the salivary glands itself, and watching for the fluid coming out from the major salivary glands ducts. It will also include examining the neck for any lymph nodes, and examination of the eye and the lacrimal system. Grading systems were also developed to quantify physical findings in patients with xerostomia in general, or those receiving radiotherapy. One of the commonest grading systems is the RTOG xerostomia grading system, which was specifically developed for patients receiving radiotherapy, but can be applied to patients with xerostomia in general. It classifies the condition of the mouth or the oral cavity into 4 grades. This applies only to patients having xerostomia for more than 3 months. The grade 1 would have slight dryness of the oral mucosa, but good response on stimulation by citric acid solution, for example. Grade 2 would have moderate dryness of the oral mucosa at rest, but poor response to stimulation. Grade 3 would have complete dryness of the oral cavity mucosa and no response at all to stimulation by citric acid. And grade 4, there will be signs of fibrosis. The investigations for patients with xerostomia falls into one of these 4 groups. Examination of the saliva itself by Sialometry, measuring the salivary output, stimulated or unstimulated whole saliva, or differentially from selective salivary glands, and the chemical analysis of the saliva. This is one form of the examination. The second group of investigations include blood tests to things like complete blood count and differentials, the autoimmune markers in the serum immunoglobulins, and erythrocyte sedimentation rate. Third group would include salivary imaging, usually ultrasonography, but also sialography has a special place if there is suspicion of a ductal problem. Scintigraphy is very useful but reserved for research or the very complicated cases. Magnetic resonance imaging is also useful in case of need to obtain a three-dimensional image of the major salivary glands. Computed tomography is not usually used because of the extra ionizing irradiation. Salivary biopsy can be taken from minor salivary glands to confirm or refute Sjögren syndrome, and fine needle aspiration from the major salivary glands is sometimes useful. Sialometry refers to standardization and validation of an objective technique to collect and measure salivary flow rate. It can determine exactly the quantity of both resting and stimulated whole saliva or individual saliva from specific gland under a set of standardized conditions. Because the normal flow rate would vary due to diurnal variations, hydration, food intake, and other factors. At rest, the salivary flow rate is somewhere between 0.3 and 0.4 milliliters per minute, the whole saliva flow rate. This can increase 5 times on stimulation by chewing, for example, to up to 1.5 to 2 milliliters of saliva per minute. These figures can be used to determine what is abnormal. For example, if the unstimulated whole saliva flow rate is less than 0.1 milliliter rather than 0.3 to 0.4, and the stimulated salivary flow rate is less than 0.5 milliliter per minute rather than 1.5 or 2 milliliters of saliva per minute, then this can indicate objectively hyposecretion. Saliva will be collected for a specific length of time. This is usually 2 minutes for the stimulated whole saliva and 5 minutes for the unstimulated whole saliva. You start first with the unstimulated whole saliva flow rate and then follow this with obtaining the sample of the stimulated whole saliva. When the patient is asked to chew on a standard piece of paraffin wax or a gum base and repeat the test in the same way, like spitting of any collected saliva in a standardized tube without swallowing it. The amount of saliva collected, whether stimulated or unstimulated, can then be obtained by weighting the tubes and subtracting its pre-weight from the newly weight after being loaded with saliva. The values would be expressed in grams per minute, which are considered equivalent to milliliters per minute. To obtain an individual gland sialometry, like saliva from parotid gland, 2 methods can be employed, either cannulating the parotid duct with a polythene catheter, or better still, using Carlson cretendon cups. These cups are non-invasive and safe to use. They are double-chambered cups. The inner cup is placed directly over the ampulla of the parotid orifice. The outer chamber is connected to a suction device, and this suction would keep it in close contact with the oral mucosa during the process of collecting the saliva from the parotid orifice. The 2 chambers are separated by this shelf. This ensures that the saliva produced is sucked from the parotid gland only. The salivary gland ultrasound grading system was developed to be used in patients with xerostomia in general and with Sjögren's disease in particular. The grading system depends on 3 things: the major salivary gland contour, whether it is regular or irregular, the echogenic area, usually the pathological areas will be hypoechoic. If the hypoechoic areas are in the form of bands or in discrete multiple areas, and if they are in multiple areas, whether they are rounded or irregular, localized or diffuse. If the gland contour itself is irregular, then this is either grade 3 or grade 4, and the first 3 grades would have irregular gland contour. If the hypoechoic band is present, like a complete band of hypoechoic, then it's again either grade 3 or grade 4. The first 3 grades, 0, 1, and 2, don't have any hypoechoic bands. If there are multiple hypoechoic areas, if there aren't any of these hypoechoic areas, then this is grade 0. If they are localized and round, then this is grade 1. If they are diffuse but still round, it's grade 2. If they are diffuse and round but with the other 2 criteria of irregular gland contour and hypoechoic band, this is grade 3. If they are diffuse and irregular plus the 2 other things, echogenic band and irregular gland contour, it's the highest score, number 4. And these are examples of ultrasonography for normal patients in this column, and for Sjögren syndrome patients in the other 2. The upper row contains ultrasonography of the parotid, and the lower for ultrasonography of the submandibular. In the normal patients, you could see a homogeneous echo and no abnormalities in the gland contour itself, either the parotid or the submandibular. In the patients who have Sjögren syndrome, you could either see localized hypoechoic part, localized in the parotid and more generalized in the submandibular. This is grade 1 and this is grade 2, and the ultrasound score would therefore be 1 + 2 = 3. Or in a more advanced case, you could see hypoechoic bands, like bands of hypoechoic across the parotid or the submandibular. This is grade 4 in the parotid and grade 4 in the submandibular, and the total ultrasound score would therefore be 8. Scintigraphy is used in research and used in some patients using the 99M technetium pertechnetate. This is a gamma ray emitting radionuclide that is taken up by the salivary glands after IV injection and then secreted into the oral cavity. So you could measure uptake and you could measure also the secretion with the saliva. The measurement of the uptake and the measurement into the saliva are both important in quantifying the xerostomia patients, and they can grade the major salivary gland functions by a scoring system. By this, we come to the end of this presentation on dry mouth, xerostomia, the etiology, the diagnosis, and the assessment. This is part 1, and part 2, the management of xerostomia. Assalamu alaikum.